Shoulder pain. It's one of the most common things that sends us to the doctor. But man, can it be confusing? Is it a tear, arthritis, something called impingement? It's a lot. So today, we're going to pull back the curtain and show you exactly how doctors approach this. We're going to walk you through their playbook for getting to the bottom of shoulder pain.
All right, to get us started, let's look at a super common scenario. You've got a 58-year-old guy, his shoulder hurts when he lifts his arm, and the doctor says you have subacromial pain syndrome. So what's the very first thing that should be done for treatment? Have a think about that, because by the end of this, you're gonna know the solid evidence-based answer. So here's our roadmap for today. We're breaking this down into 5 parts. First, we'll look at how doctors even start solving the puzzle. Then we'll cover the really serious stuff, the red flags they look for immediately. After that, we'll dive into the doctor's toolkit, meet the most common culprit behind shoulder pain, and finally map out the road to recovery.
Okay, let's jump in. Section 1, solving shoulder pain. I want you to think of your doctor as a kind of detective here. They're not just taking a wild guess. They are methodically following a trail of clues that leads them from what you're feeling all the way to a final diagnosis. And all this detective work is absolutely necessary because, well, the shoulder is just incredibly complex. Seriously, it's not weird at all for someone to have 2 or even 3 different things going on in there at once. And because of that, doctors have to use a systematic approach. And step 1 is always about safety first, making sure nothing really bad is being missed. Which brings us right to our second part, spotting those red flags. Before a doctor does anything else, their number 1 priority is to check for any urgent, serious issues that need immediate medical attention. So, what kind of red flags are we talking about? Well, if a joint is hot, red, and swollen, that screams infection. If the shoulder looks kind of misshapen after an accident, that points to a dislocation. A new lump could, in rare cases, be a tumor. And any sudden, dramatic weakness or loss of feeling could mean a big, acute tear or even a nerve injury. You see any of these, and it's an immediate, same-day trip to the hospital. No messing around.
Okay, so once all those urgent issues are ruled out, the real detective work begins. And for that, the doctor breaks out their primary care toolkit. And it really boils down to 2 main things: asking some very specific questions, and then doing a series of hands-on physical tests. The questions might sound simple, but they are incredibly revealing. For instance, asking, "Can you lie on the affected side at night?" That's a fantastic way to figure out how severe the pain really is. If you actually can sleep on it, the issue might be something that can be managed with a wait-and-see approach. Then they'll want to know this: do you have pain when you're just sitting there or only when you're moving? See, a constant ache, even at rest, often points to a problem deep inside the main ball and socket joint, something like a frozen shoulder or osteoarthritis. But if the pain really only shows up when you do something, like trying to put on your coat, that's a big clue that the problem is more likely with the rotator cuff tendons. Plus, it helps the doctor understand the real-world impact this is having on your day-to-day life.
Right, so after the questions, it's time for the physical exam. This little table breaks down how just a few simple movements can help pinpoint the problem. They'll check your neck movements because sometimes neck pain masquerades as shoulder pain. They'll do a cross-arm test for one joint, check your rotation for another, and use things like the painful arc test to check on the rotator cuff. It's a process of elimination that narrows down exactly where the pain is coming from.
So, after all this investigation, where does the trail usually lead? Well, let's move on to Section 4 and meet the most common diagnosis a doctor will make in their office: subacromial pain syndrome, or SAPS for short. This is pretty much the usual suspect when it comes to shoulder pain that wasn't caused by a specific injury.
So what exactly is SAPS? It's not one single thing. Think of it more as an umbrella term. It basically covers a bunch of different conditions that all cause pain in that little space right under the bony point of your shoulder. That's where your rotator cuff tendons and a little fluid-filled cushion called the bursa live. And here are just some of these specific issues that fall under that big SAPS umbrella. It could be tendinopathy, which is basically wear and tear on a tendon, or bursitis, which is when that little cushion gets inflamed, or you might hear the term impingement, which is literally what it sounds like. The tendons are getting pinched when you lift your arm. As you can see, it's a pretty broad category. Okay, this brings us to the final and, let's be honest, the most important part, the road to recovery. Once a doctor has figured out its SAPS, what's the actual evidence-based game plan to get you feeling better? Well, the science points to a very clear step-by-step plan.
And the order here is everything. Step 1, the foundation, is a personalized exercise program, usually guided by a physiotherapist. Step 2, you can combine that with anti-inflammatory drugs to help manage the pain. And then only if that isn't cutting it does a doctor move to step 3, thinking about a corticosteroid injection. And this is where the evidence is just crystal clear. Major studies have put these treatments head to head, and the results are really telling. An injection, sure, it can give you some great short-term relief, maybe for a couple of months. But physiotherapy, that provides the real, lasting, long-term benefit. And why is that? Because it actually fixes the root of the problem by making the muscle stronger and improving how your shoulder moves. The shot is a Band-Aid. The exercise is the cure. Which brings us right back to our opening question. For that 58-year-old man diagnosed with SAPS, what is the #1 first-line best recommendation? The answer, backed by a ton of scientific evidence, is a referral to a physiotherapist for a personalized exercise program. It is hands down the most effective treatment for long-term recovery. And that's really the whole playbook right there. Understanding why your doctor is suggesting a certain path, that's not just trivia. It's the thing that transforms you from someone just receiving care into an active, empowered partner in your own recovery.